Supervisor in the Division of Program Support and Quality Improvement at the Department of Drug and Alcohol Programs. And I just wanted to let everybody know that we have started to record this meeting. So if you do not want to be recorded, you can exit the meeting right now. And the good news is that this presentation will be available on the DDAP ASAM transition website after the meeting today. So again, if you don't want to be recorded, you can exit right now and you can access this training on our ASAM transition website after the meeting. So welcome everybody today. Thank you for joining us. Very excited today to be talking about the topic of special populations as it is discussed in the ASAM criteria 2013 edition. And very excited today to have three program representatives from the Division of Program Support and Quality Improvement, Mary Hickok, Gloria Gallagher, and Greg Hummel, all presenting today. And you can see a couple of them kind of waving their hands. So really excited to have them presenting today. And so a couple of reminders. So for those of you who have been able to join us before, you kind of know these, but for those of you who are new, so we encourage people to submit questions related to the topic. So today the topic is special populations. We encourage people to submit questions related to that topic 7 days in advance of the call to the ASAM email account noted here. So if you want to submit a question, in the chat during the presentation today, please do that. Our team is busy kind of recording those questions that we're getting, and we will draft responses and post those to the ASAM transition website after the call. So don't hesitate to put questions in the chat. Just please know that we're not going to be responding to those questions during the presentation. So please do that. I believe we got one question through the ASAM email account today related to the topic. So we're looking forward to kind of providing a response on that question. And as I mentioned before, the call is being recorded, so you have another opportunity here to leave the presentation if you would like to do so, and the content of what we're going to be presenting will be on the ASAM transition website after the meeting. We always welcome suggestions for future call topics, and you can do that by submitting those to the ASAM email account noted here on your screen. So always welcome to those suggestions from folks. We've gotten a couple of them, and this is really the reason why we're doing special populations today, is because we've gotten so many suggestions about that topic and presenting on that topic. So just want to give a disclaimer here, and I think this is more important now than ever. So the ASAM criteria is required, by Act 70, so that all drug and alcohol treatment providers who receive funding for treatment services under agreements with single county authorities and managed care organizations. So it is a requirement for all providers across the Commonwealth who fit that criteria. And the information presented today is just an overview, but it doesn't even touch on all the material that is located in the ASAM criteria 2013 edition. So, we have a lot of resources on our website, which I'm actually going to go through in a minute here. But the reality is that those resources kind of summarize what is in the ASAM text, and you really understand ASAM in its entirety by looking at the text start to finish, front to back. So just really encourage folks today, after we go through the special populations, open up that textbook, have the textbook open while we're doing the presentation today so you can follow along, and you will really get a better understanding by taking that approach. So just want to really want to highlight that. And I also just want to say that there's a lot of very good trainings available on the DDAP website related to the ASAM criteria, and I encourage everybody to check those out as well. There's a new co-occurring one in particular, one that I would really, really recommend. So going on here. All right, so I am actually going to try to share my screen here because I am going to give you a little overview on some updates to the ASAM transition website. So I'm going to share my screen. Mary, can you tell me if I'm presenting this? Can you all see this?
I see it, yes.
Okay, perfect. So this is the ASAM transition website. Many of you have been to this website. And this is, I'm bringing this up today because we have recently completed a lot of updates to this website. So just wanted to let folks know that beginning in really late spring and summer of 2021, it would have been, the QI team has really made it a priority to go on the website and to review documents that maybe are not so helpful anymore, or maybe not even very accurate anymore, and to put those documents in an archive so that we could clear up space on this website to ensure that the most helpful documents to providers and others are available on this ASAM transition website. So really excited to announce that as of a couple weeks ago, we were able to kind of finish the process of updating the website. And just wanted to highlight a couple of things here. So just a summary of all the changes that we've made is located on the top, this little document right here in the highlighted section. So you can click on that for more information about the process that we followed in our rationale. And the newer documents, we outline which older documents those replace. So that is really helpful. We have a new document, or an updated document, the guidance for the application of ASAM right here, which is really important for folks to take a look at if you have not already. So please be sure to do that. And then we, obviously maintain our ASAM aligned 2.5 and 3.7 providers list right here. And I just wanted to take a second we've gotten a lot of questions recently about 3.7 versus 3.7 withdrawal management, and asking us where our 3.7 withdrawal management list is. So we actually don't have a 3.7 withdrawal management list because the level of care that we are formally aligning is 3.7. So that is located here. And then we have all of our level of care specific checklists still available on the website. Those have not changed. And then we've updated all the trainings that we have available right here. And we include all of, like I mentioned, all of the ASAM monthly technical assistance calls right here, along with the questions and answers that we received. So those are all available for folks who were not able to attend, or their staff wasn't able to attend. And so just wanted to make sure people understood that this is a new and improved website. If you haven't, please take a moment to check this out. And we are really, really happy with some of the changes that have been made. So I'm going to stop sharing my screen here. All right. Gloria, would you mind putting the PowerPoint back up? And while Gloria is doing that, I am really excited today to talk a little bit about some of the learning objectives that we're going to be covering, and just the general topic. So the ASAM criteria is a very rich textbook, and it has a lot of information related to a variety of topics. And I am going to pull up the right slide here. So the topic that we're going to be talking about today is special populations. And just really wanted to make sure that you all understood that by the end of the presentation today, you should have a better understanding of what these special populations are as identified in the ASAM text. You'll know where to find this information. In the ASAM text, there's going to be page numbers provided, which is very helpful. And again, if you have your text, please open that up and follow along today. And we are hoping that you have an increase in the knowledge of additional considerations related to these very unique special populations. And please know that, this is not a comprehensive list. So like I mentioned before, please be sure to read the text in its entirety. And we just cannot stress that enough. So we think this is going to be a really helpful presentation today, and very excited to have Gloria, Greg, and Mary presenting on this. So the different groups that we're going to be covering today are older adults. We're going to be talking about parents or prospective parents receiving substance use disorder treatment concurrently with their children. We're going to be talking about individuals who work in safety-sensitive occupations. And then we're going to be talking about individuals who are in criminal justice settings. So without further ado, I am going to go ahead and I'm going to turn it over to Gloria to take the lead on discussing older adults.
Thank you, Kathleen. Again, I'm Gloria Gallagher, and I am going to be talking about older adults as it applies to the ASAM criteria. And like Kathleen said, there's a lot of information in the special population groups. Disclaimer, I used most of the language that ASAM uses. They do use words like addiction and and the term relapse. So just to stay in line with the ASAM, I kept a lot of the language in there. Just wanted to let everybody know that ahead of time. But for ASAM purposes, we're going to consider an older adult to be about 60 and older. This is a very rapidly growing population. People live longer today. And there's many variables pertaining to older adults that require some modifications to how the ASAM criteria is applied. Just to give you some context, according to the US Census Bureau, in 2030, watch out, all baby boomers will be at least 65, which expands the older adult population so that 1 in every 5 Americans is projected to be retirement age. Later that decade, by 2034, it's projected that older adults will outnumber children for the first time in US history. So at all levels of care, consider mobility limitations. At level 2 programs, mobility limitation may be that older adults do not drive, so they may not have the ability to get to an IOP or a community-based recovery meeting. If they're in residential care, mobility limitations may be because of their physical condition or even cognition issues. ASAM suggests assigning a buddy system for new patients in residential care. Many older adults use Medicare as their primary form of insurance, so check their insurance coverage, including Medicare Part B premiums. Medicare can be restrictive. At level 2 programs, if a level 2 program is affiliated with a general hospital, they may be more likely to take Medicare reimbursement than a typical freestanding facility. If higher intensity residential level care is necessary, it's possible that you may need to be somewhat creative and combine level 2.1 or 2.5 with a supportive housing option like assisted living. As people age, they have more medical problems, which is exacerbated by substance use. ASAM recommends a comprehensive, older adult-focused history and physical at intake and assessment, if possible, by a geriatrician. Make considerations for the different medications and medication interactions for chronic conditions that can contribute to cognition, alertness, mobility, or coordination. Home health care may be needed to assist with safe use of prescribed meds or case management services for multiple chronic conditions. Older adults often have issues with social isolation and they may live alone, so assisted living may be a conducive environment for them. They may be the primary caretaker of a spouse that has even greater needs, and they may deny inpatient services and can't go to residential care. You may need to look into a third-party van service for transportation and consider mutual aid meetings as a vehicle to support. You can already get the impression that a necessity for comprehensive coordinated care is necessary. When we talk about staff, it's important. It is as important as the actual training that the attitude toward adults in general, towards older adults in general, be based in dignity and respect. Staff should like working with this group. Ageism can manifest in caretaking or in pessimism of whether they can progress in treatment. Avoid using terms like addict and alcoholic. Instead, staff should help the older adult to connect their substance use with the results of their use. The best results can be expected when staff is experienced in dealing with the physical, psychological, social, and spiritual issues to older adults. Clinical supervisors should monitor the possibility of counter-transference that may occur, staff treating the older adult like a grandparent or not holding them as accountable. Age-specific treatment is associated with higher outcomes over mixed-age treatment. If possible, include an option for senior-specific groups. Treatment should be paced to the individual's physical and cognitive capabilities and limitations. Treatment should be individualized. CBT therapies are effective with older adults, especially to address emotional states which pose significant risks for a reoccurrence of symptoms. And there should be an educational component. There should be skills to work on building social support, and family counseling should address family of choice, family of procreation, and family of origin. Confrontational style therapies should be avoided. Older adults are at a point in their lives when they are exerting or re-exerting their independence, and how they're spoken to is very important. A comprehensive assessment should include sensory limitations in hearing and vision and activities of daily living. Depression and anxiety are common co-occurring problems. A major factor in attempting to assess older adults is the issue of shame and guilt. They are often dealing with their own judgmentalism. They also may have strong religious beliefs and could view their use from a moralistic perspective. Documentation should be consistent with requirements in whatever level of care they're enrolled. It is possible that an older adult may not meet many of the diagnostic criteria in the DSM-5 due to factors other than substance use. This can result in the appearance of a less severe SUD. They are still at risk. You may consider using the ICD-10 under harmful use to capture those variables. Let's talk about some of the highlights older adults could experience in the 6 dimensions. And keep in mind, ASAM addresses spirituality across all 6 dimensions. And this could relate to a sense of purpose or meaning, something they could be contending with at this point in their life. Dimension 1 is important because of the aging body. Acute intoxication may mask a stroke or dementia. The time spent in withdrawal management could be longer for the older adult because of the delayed metabolism of substances, as well as the longer time for them to gain full cognition. Dimension 2, the aging process, makes older adults more likely to have chronic medical issues. In Dimension 3, depression, anxiety, and dementia are common. Be aware that many older adults associate symptoms of depression as a result of getting older. They often report depression as a physical problem. And suicide is a major concern, especially in white males. In Dimension 4, readiness to change may depend on the age of the onset of their SUD. In Dimension 5, the 2 most common reasons for an older adult to return to using are negative mood and social pressures. More significant medical, psychiatric, cognitive, and recovery environment problems are associated with older adults that have earlier onset SUD. Older adults with later onset typically have more achieved success in life before they began using and experiencing problems related to their substance use. So they're more likely to have a higher education level and a stable career or employment. They may have better coping skills in general. Another group that may present with extra challenges are older adults that may have used after a long period of recovery. Dimension 6 is where older adults are going to present with the most needs. Mobility presents problems with getting to support groups. Some peers may not be as receptive to them. It is helpful to find a senior center that may facilitate a 12-step meeting. It's important for them to get connected. Many older adults are very lonely and isolated, and fixed incomes may cause them to choose between rent, food, and even medicine. Whatever level of care is considered, the literature suggests better outcomes when a less intensive level of care is considered for an older adult with later onset addiction and more intensive care for earlier onset. Remember, later onset, better coping skills; earlier onset, less coping skills. In both cases, consider specialized medical or psychiatric treatment to stabilize dimensions 1, 2, or 3 before continuing with addiction treatment. When assessing for continued service, treatment may need to be longer and slower. When patients have been unable to resolve problems in the level of care for which they were placed, it's often due to the worsening or development of new problems in dimensions 2 or 3. Utilize an assessment to determine whether a transfer to a different type of treatment or different intensity level is needed. During discharge planning, keep in mind how the older adult will follow up with medical care for chronic conditions. They should be linked with aging services and other community-based services and mental health services as needed. Again, comprehensive coordinated care is very, very important here. And focus on the continuum of care that includes community resources. And with that, I'm going to turn it over to Greg to talk about, Mary, to talk about parents or prospective parents.
Thanks, Gloria. So we're going to switch gears a little bit and talk about parents. But before we really dig into it, I just want to take a minute to talk about becoming a parent. So for most of us, once we become a parent, it really becomes key in our identity and how we define ourselves to the world. And I think that all parents strive to be a good parent. So when we're labeled as a bad parent, or if we feel that we're a bad parent, it really carries this shame or social stigma with it. And oftentimes, when parents or prospective parents come to us, they have been labeled or they may identify as a bad parent. So part of what we need to do as providers is to support that parent and help them acquire a positive perception of their ability to parent. So while we're doing these things, we might have to help them manage past traumas that come up. And this could be related to their parents growing up, or maybe be triggered by them parenting their own children. And in addition to these things, they might be trying to manage a relationship with a life partner or a significant other, or they may be trying to manage things as a single parent. So you can see, even before we really dig into the material related to this special population, there's a lot of layers and nuances at play. All right, so we're briefly going to review the subpopulations. We're going to describe some of the additional requirements and considerations for serving parents with children according to the ASAM text. And while the subpopulations are noted, it's important to acknowledge that historically there's been a focus on women with children or pregnant women. And the ASAM expands on this to include men responsible for children as well as women. So it's important to note that the term parents can refer to male or female. Oftentimes we focus on a single parent, but I also want to point out that parents it should also be considered that parents can be a couple, not just an individual. And last thing I want to point out is the ASAM text will often refer to the term child, but this can mean more than one child or children. All right, so what are we talking about? Well, we're talking about parents, male or female, with young children or pregnant women with substance use disorders or co-occurring disorders that are appropriate for level 3 or level 2 services. And just to be clear, the ASAM has requirements and recommendations for level 2 services as well as level 3 services related to therapies and support systems. But the items I'm going over today are in addition to those things. So again, it's this added layer to serve this special population. Now, I'm not going to go over the chart in its entirety just because there's a lot of information here, but I am going to point out a few things. And if you look at the top, you can see that there are page numbers referenced. So I would encourage you to just go ahead and, if you're interested in more information, check out the page numbers listed. So for qualifiers, for level 3 services, a parent with a child must also demonstrate that that parent-child combination is in imminent danger, meaning that the abuse or neglect is significant enough to endanger the child, or there's a significant stress and potential of harm for that parent if they are not in a 24-hour treatment setting. The level 2 qualifier is that a parent with a child has to demonstrate that that parent and child would be adversely affected if they're not in treatment concurrently. All right, general information around a setting. Sometimes additional licensure may be required, and this is related to childcare or when services are provided and parents are not in the same room. Oftentimes, parents and children are only in the same room when that parent, when there is either family therapy or there's parent training. Additional considerations for a residential setting. The setting should really be conducive to that parent-child routine. So think about a bedtime routine, maybe meal prepping or sitting down to eat meals together. For setting in a level 2 service, sometimes mixed gendered groups are not appropriate, especially if there's a history of sexual abuse or domestic violence. For support systems, think about Maslow's hierarchy of needs and those basic needs, such as emergency funds, food, clothing. These are those items that just really establish a safety net for that family. And of course, that ties into case management services, because oftentimes it is through those case management services that those basic needs can be met. As far as staff goes, we are looking for clinical staff that are trained in child development and positive parenting, among other things. And we really want them to have skills in couples therapy or family therapy. Also, it's good if providers are able to include current life partners or non-custodial parents whenever possible, if it's appropriate. With regards to therapies, interventions should really be aimed at increasing understanding of child development. And we want staff that are able to observe, coach, and encourage those positive interactions between the parent and child. So at level 3, we're motivating that parent to provide nurturing care for their child or for their children. And at that level 2, it's really about implementing parenting skills. With regards to assessment and treatment, it's going to be important that you determine the extent to which that parent-child relationship has been affected by substance use disorders or mental health issues. And additionally, stresses of parenthood with regards to recovery should also be considered. And the ASAM recommends that a separate clinical record be maintained for each child or children. And again, that's separate from the parent. And with that, I am going to turn it over to Greg, who's going to tell you a little bit about the next subpopulation.
Thank you, Mary. Welcome, everyone. Thank you for joining us today. And we're going to be talking a little bit about factors involved in serving the accompanying child. Mary did a nice job of discussing a lot of the aspects of this. So this is going to be mainly focused on the factors for the child in treatment with the parent. Research shows that children who have parents suffering with SUD or co-occurring disorders are at a higher lifetime risk for anxiety, depression, relational issues, attachment issues, and obviously their own potential development of SUD issues. Treating concurrently improves family relationships, emotional and social functioning of both the parent and the child, improved health of the child and the family system throughout the lifespan. So this is one of the reasons why it's such an important topic. The setting, again, as Mary mentioned with the chart, residential or level 2, these are specialized programs. The text talks about some level 1 programs that may offer, treatment to the parent and then have childcare available to the children. But this is more of a specialized setting with all of the concomitant requirements, specialized licensing, as Mary mentioned before. The welfare and safety of the child is paramount in this environment. There's special considerations that we need to take into account. DDAP regulations, for instance, have requirements in the physical plant regulations for programs that treat children. Outlet covers on the electrical outlets is one example. Children in treatment may differ widely in age range from newborn to school age, and therefore, we need to have a developmentally appropriate and suitable environment to provide the requisite activities such as individual group therapy, play therapy, and things of that nature. The culture of the environment supports physical and emotional safety for everybody, but again, especially the child, and focus on empathy and not authority is emphasized. Support systems. In addition to the support systems that we found in the chart, we need to have awareness of pediatric care being available 24/7. Now, this can be on site or can be through contractor referral, specialized medical care for children when needed. Infection control protocols need to be really, really clearly defined and in place to stop the spread of infectious diseases. Anybody with kids knows why that is. One kid gets sick, they all kind of get sick. So we need to make sure that there's a process in place for that when it comes up. The educational needs of school age kids has to be considered. So working closely with schools is important, as is case management, as was mentioned before, and transportation to make sure the child and the family can get to where they're going. Staff appropriately credentialed to work with children. We talk a lot in ASAM about working within the scope of your practice. These individuals need to be able to identify and address signs and symptoms of a variety of different kinds of traumas that may have befallen the family, and able to provide a wide range of age-appropriate interventions to address those issues. Therapies, we're going to focus on the child therapies. They need to be developmentally articulated to the age and learning capabilities of the child. We want to try to decrease the impact of ineffective parenting and increase resilience and positive social skills in the child and the family system. Planned activities to engage the parent and the child and to build healthy attachments, again, focusing on that, the positive aspects of the parent and limiting that reflective on the negative parenting that may have been they may have been aware of. Addressing developmental delays that have been identified in assessment, always tailoring to the child's developmental stage and ability to comprehend. Again, the parent needs to have the rehabilitative and positive skills, and these exercises should be conducted on site with the parent and the child. And as was mentioned before, bringing in the other parent or other important adults or stakeholders into the treatment is something that we can consider at this point. Assessment and treatment plan review. Again, for the child, we want to make sure we're utilizing age-appropriate tools for the biopsychosocial, any questionnaires or rating scales, to determine medical and clinical necessity. The parent information is used here to help with collateral information on the child's assessment. Documentation, as mentioned before, there should be a separate clinical and medical record according to ASAM for the child, and the child's record is going to contain everything that you would think the record would contain: the assessment, the service plans, progress notes, releases, correspondences, and any other documentation. Issues across the 6 dimensions. In Dimension 1, mainly the effects of the parent's Dimension 1 issues are going to be noted here. In Dimension 2, we want to make sure that we have a current and historical medical assessment, including biological and genetic vulnerabilities, assessing for fetal alcohol syndrome spectrum disorder, and obviously any tuberculosis or other communicable diseases needs to be done at this stage. In Dimension 3, the normal developmental progression is going to be adversely affected by the concomitants of the parent's addiction, any abuse or neglect, as was previously mentioned. And these are expected to kind of detract from any healthy adaptation. And again, we want to make note of that. In Dimension 4, child's well-being can be assessed, and positive adaptation, despite adversity and risk that they've encountered, can be a guide to interventions that are suggested here. The child's readiness to change is related to their overall emotional and social development. In Dimension 5, the risk of the child returning to the same or similar environment. Now, this can be related to relapse, but also some socioeconomic and other considerations that need to be addressed at this stage. And again, in Dimension 6, current and future issues related to stable living and improving family support systems as needed. And with that, I'm going to turn it back over to Gloria to talk about the unique needs of pregnant and postpartum women.
Thanks a lot, Greg. Pregnant women who receive targeted interventions have a higher rate of prenatal visits and improved birth outcomes. Most women want what's best for their babies, but pregnant women, especially those with a higher severity of SUD, especially if she is afraid of losing custody of her baby or if she feels there's a chance of being charged with abuse or neglect, may be reluctant to seek treatment. It's important for the medical community to take on the role of understanding ally that providers discuss the importance of treatment with women that are actively using. Treatment engagement increases the mother's ability to parent in recovery, for the baby to be born drug-free, and that CPS, if they are involved, will support with the support of mother's right as to parent, as she progresses in her recovery efforts. So this is, I'm not going to be telling providers that typically serve this population anything that they don't already know. You're experts in this field, but there are a lot of gaps that we can fill surrounding that in the integration of care, the medical community. There's a lot of stigma attached to, pregnant women that are actively using, and a lot of judgment, and that judgment unfortunately prevents women a lot of times to seek, much less treatment, but even prenatal care. The setting for providing services to pregnant and postpartum women is consistent with, again, residential and level 2 criteria, and accommodations for physical limitations like climbing stairs or if bed rest is required. Support systems, again, residential and level 2 with an emphasis on healthcare needs, prenatal care, labor and delivery. Pregnant women that use opioids should have access to medication-assisted treatment to stabilize the woman and protect the fetus. And pregnant women receiving MAT should be counseled on neonatal abstinence syndrome and what to expect at delivery. All staff should be trained in accessing medical services related to prenatal care, labor, and delivery. Staff, especially clinical staff, should be trained on the various outcomes of pregnancy. This includes a healthy birth and any complications that could have a profound effect on the mother, staff, and other patients. They also need to be trained in a multi-dimensional approach to individualized care and how to de-escalate physical altercations that may occur within the facility and otherwise. Therapies and treatment should be consistent with the needs of pregnant women and should be interdisciplinary, comprehensive, evidence-based, and coordinated to address the issues related to prenatal, perinatal, and postpartum mental and physical health concerns, as well as psychosocial and practical issues. Pregnant women require specific services by the very nature of being pregnant, but each woman is different and services need to be individualized. Staff should be proficient in accessing her current situation and reproductive history in the following areas. Was this a welcome pregnancy? Is this the first pregnancy? How many other children does she have and with whom are they living? Are the children currently separated? What role, if any, does CPS have? What were the circumstances of the pregnancy? The impact of sexual abuse on prenatal care visits and delivery should be examined and addressed. Motivational strategies hopefully have been used to assist the woman to get into treatment. Those strategies should continue to engage in recovery. The assessment and treatment plan review will follow, again, residential and level 2 criteria with the physical needs and well-being of the woman and the fetus. Use an individualized assessment in all 6 ASAM criteria dimensions. And if the assessment demonstrates a higher probability that substance use behaviors present imminent danger to the woman and/or her fetus, refer to the level of care that is most appropriate for her situation. And services continue after delivery. Women are very vulnerable and at a higher risk for returning to use once the baby is delivered. We know for many reasons: postpartum depression, shame and guilt, hormones, feeling overwhelmed, just to name a few. This is the time that is critical for mother-baby attachment. Once discharged from residential care, the continuum of care is crucial. Postpartum women need continued support that includes community resources and other services depending on their individual needs. and I will hand it back over to Greg.
Thank you, Gloria. And this is the final subpopulation with the parents section, the parent and child connected with the court for reunification. This is a kind of a short section, and then we'll talk about the safety sensitive occupations. Just want to make sure that, that the ASAM recommends this the treatment provider bears the responsibility for working with the court, court-appointed guardians, and anybody else, any other stakeholders that are involved in this situation. Collaboration with the court system is very important. You know, we all understand that substance use treatment is a long-term endeavor, and this perspective is not often always shared and does not align with courts' expectations or timelines established by the federal government in the Adoption and Safe Families Act. Again, it's going to be the responsibility of the treatment provider to make sure that the communication and collaboration with everyone involved takes place as seamlessly as possible. Staff need to be well versed in laws and rules regarding reunification. And any decisions that are made regarding progress or lack of progress, or have a high likelihood of impacting decisions on custody. So we need to be even more careful when we consider what we're going to say there. Safety sensitive occupations can be found on pages 340 to 349. So it's a little bit of a longer section. We're going to skip over some of the stuff that's in the slides, but the slides will be available after the presentation. We'll make that available. So we're going to skim over this a little bit more. The text talks about 4 groups: police officers, healthcare professionals, airline pilots, and attorneys. I would say any pilot, but we can see the need in these areas. We can all think of some other ones too that would probably fit into this parameter. Talks about the distinctive qualities of these occupations. Responsibility to the public is greater than the general public, in terms of the effects of their addiction issues. The cohort specific treatment is discussed as being very important. Just because of the nature of the issues, it might be easier for them to disclose in front of people who have been through similar things. Direct access to addicting substances. There's a more comprehensive list of folks and their access on page 341 of the text, and difficulty accepting the role of a patient for various reasons. And it gets into some specifics in the text on page 342 about that. The setting, obviously, this is the one thing that's really important most of the time in ASAM. It talks about the least intensive level of care that's effective. And for this, due to the one and done nature of a lot of these occupations, not a lot of tolerance for relapse, they recommend using the level of care that's going to be most effective, regardless of whether it's the least restrictive. There's some issues that we want to discontinue work until these 5 or 6 things are met. So the person shouldn't be at work while they're seeking treatment. Support systems. There's a lot of material about professional associations for pilots and doctors and lawyers, occupation specific groups. There's some geographic considerations that are worth noting, that some of these programs may not be geographically adjacent to where the people are. So that needs to be taken into consideration. Profession specific awareness of staff, training and supervision to avoid judgmental responses to some of the things that the staff may hear. Trauma recognition in these occupations is super important. Again, therapies and in therapy staffs and support systems talks a lot about profession specific groups and support being a key to effective and ongoing recovery. Focus on job and career issues, drug safety and refusal skills. Medication management issues in terms of prescribing and knowing what substances that can be prescribed to certain occupations. Assessment, there's some stuff in there that we need to be aware of in PA, with collaborating with the employer and EAPs and things like that may be restricted by 255.5. So just keep that in mind. There's some good discussion about the implications across the 6 dimensions. in the book. So I recommend looking that over. There's some things in there mainly related to dimension 4 is difficult to gauge the readiness to change because they may appear to be super motivated for treatment because they want to get back to work. But as we talked about briefly earlier, they may have difficulty accepting the role of a patient. So it's a very nuanced assessment there. Documentation, again, there may be some limitations there definitely are some limitations of what can be disclosed and shared with employers. And I'm going to turn it back over to Mary now for persons in the criminal justice setting.
Thanks, Greg. All right, so we are in our home stretch, and we're going to talk about persons in criminal justice settings. So I think it's important that we have a clear definition of this population. So individuals with substance use disorders that are incarcerated or under community-based supervision. So our common element is that these individuals are accountable to comply with a criminal justice sanction. And we can find these individuals in jails, prisons, work release centers, and other community settings. So today we're going to look at the different factors that affect treatment, the ASAM recommendations around those factors, and specific actions that you as providers can take to increase positive outcomes for this population. So with regards to assessment, sometimes the court will mandate treatment, but after you've completed that assessment, there's no indication that treatment is needed. So in this case, best practice is to not recommend treatment. The ASAM suggests that you as providers try to work with the courts around negotiating for that 0.5 early intervention or education. With regards to treatment, sometimes readiness to change can be an issue. Maybe an individual's primary motivation is to simply get off probation, and it's not that drug and alcohol treatment. When this occurs, the ASAM suggests that providers use motivational interviewing techniques and connect that to the probation and the parole plan, and ultimately drug and alcohol and substance treatment. So for this slide, I've kind of broken down things that providers can do before incarceration and things that providers can do after incarceration. So before incarceration, if a controlled environment is forcing an abstinence from all MATs, best practice is to try to do a taper with a doctor before incarceration. I know that this is something that is easier said than done, but again, best practice to do that taper. I do just want to talk about MAT for a minute here as well. So Pennsylvania has definitely made some strides with offering MAT services within prisons and jails. And I suspect that we're also going to see additional changes related to the criminal justice system. And this is mainly around the suit that the U.S. Department of Justice has filed against the Unified Judicial System of Pennsylvania. And essentially the suit says that they're in violation of the Americans with Disabilities Act by limiting the use of legally prescribed medication for opioid use disorders. And that's for people that are under court supervision. So basically the lawsuit is saying it's not okay to force people into abstinence if they've been legally prescribed MAT. So again, just note that we'll probably see some changes around this in the future. After incarceration, employment is a statistically significant predictor of criminal recidivism. So if you as a provider offer case management services, or if you can get people linked in with case managers and they can help them get a job, that will exponentially increase positive outcomes for this population. Also, consider providing naloxone immediately upon discharge or as soon as possible. There was a study that was done in 2010, and it shows that individuals that are incarcerated or were incarcerated are at an increased risk of drug-related overdose in that first 2 to 4 weeks upon release. And there was actually a study done in 2016 that indicates females actually have a higher rate of post-overdose upon release. So one of the ways that some other states have tackled this particularly vulnerable time for individuals is to actually set up naloxone vending machines. Los Angeles and New York both have programs. Some vending machines have actually been set up on the prison floor, and other vending machines are available as people are walking out the door. And in both of these instances, lives have been saved because this naloxone was available to individuals. Also just want to mention, if that individual had any type of medical treatment in prison or in jail, it's suggested that you obtain those records just for continuity of care. Additionally, if you're able to work together and have good communication with that criminal justice system, that can go a long way too. If you are able to come up with a plan with the client, the parole or probation officer, and you as the provider, if that client returns to use that does not equate to an automatic return to jail or an automatic sanction, that can have a really positive impact on that individual as well. And just going back to education, anytime you have an interaction with a criminal justice person, you have the ability to educate them around substance use and mental health issues, just because they simply may not know. And if you are comfortable and you want to be even more proactive, you can always reach out to your local representative and you can educate them as well. Again, they might not know. All right, so the criminal justice system and SUD treatment system is a really complex topic, and that's even under the best of circumstances when we remove any issues of race and class. So as providers, there's ways for you to influence and improve treatment within the intersectionality of criminal justice, and these are to help clients with employment, to distribute naloxone as soon as possible, to recommend treatment that's based on the assessment, and to work together to improve communication. And with that, we're going to go into our question and answer. All right, so our question. The ASAM talks about providing services for parents and parents with children. The residential programs we contract with only permit pregnant individuals or women with children into their programs. Is there any consideration of what to do with men who are the primary caretakers of children but need residential treatment? So I talked about this a little bit earlier in this presentation, and the ASAM acknowledges that historically we just have this focus on women and women with children or pregnant women, and we definitely have this gap in service for men who care for children. And as this question illustrates, the Pennsylvania treatment system is really reflective of this as well. So I did learn, though, that Pennsylvania in Allegheny County actually has a program that can accept men with children. It is a residential program. However, it is only open to men involved with Allegheny County Children, Youth, and Services. So that's a little bit of progress, but obviously there's more opportunity for Pennsylvania. So if we have any providers that are interested in filling this gap, DDAP would be happy to provide additional technical assistance around this. Now, in the meantime, until these programs are up and running, I would suggest that you treat this the same way that you would a woman who has multiple children that can't be accommodated in a residential setting. So that really would be to offer that next lower level of care, which in this case is likely to be that 2.5 or PHP level of care. And with that, I am going to turn it over to Kathleen.
All right, thank you so much, Mary. And I just want to take a second to say thank you to the entire quality improvement team. Gloria Gallagher, Mary Hickok, and Greg Hummel, you all did a fantastic job today presenting. I can't say thank you enough. This was really, really fantastic. So in front of you, you can see some announcements and reminders. The next ASAM TA call is going to be on Monday, April 4th. and we have not decided what the topic is. So as always, if you have a suggestion, we would love to hear those. Please send those into the ASAM account, which is on the screen in front of you. And you can also type some of those suggestions in the chat box if you want to. We have a couple minutes left. We would love to see those. And I just want to remind people that, you know, we know that there's a lot of change happening and continuing to happen. And so if you have questions, or if you just need to talk to our team, if you want to put aside an hour to do technical assistance with our team, we are more than happy to sit down with virtually sit down with folks to do technical assistance really around any ASAM related topic. So please don't hesitate to reach out to us. We really want to work with our partners on this. So again, the ASAM resource account is on the screen in front of you, and we would encourage you to reach out if you have any questions or concerns. I just want to say thank you again today for taking the time to be on here. This meeting will be available on the website, the recording and the slides. So if you had staff that were not able to attend and you want them to see what was discussed, you can access this on the ASAM Transition website. And with that, that is all we have today. Thank you again for joining us. We're going to be staying on for the next about 3 minutes or so. If you have any questions or if you have any suggestions for future topics, I hope you have a wonderful day and that you can enjoy this weather. Thank you.